The next speaker is Professor Stefan Anker. You all know him. Not only has he a truly remarkable publication and clinical trial history, but he's also the founding president of SCWG and the editor-in-chief of Journal of Cachexia, Sarcopenia and Muscle. And by doing this, he has kept a flashlight on cachexia for all stakeholders and thus moved the field forward for decades. A lot of us are working with cachexia and muscle, but not necessarily the cardiac muscle, which is one of your specialties.
Thank you for allowing me to give this talk. I checked in March. I was originally invited to give this talk title about methodology of cancer cachexia trials. I persuaded her to make it focused on cardiac wasting cardiomyopathy, but given the developments of a few trial programs turning out the way they have turned out, I thought maybe I should do both and basically speak about cancer cachexia trial methodology and of course also cardiac wasting. The other thing is, yes, Cachexia Journal, Society, I'm the founder, co-founder, and this will be a little relevant in one or two slides of Actimate Therapeutics. And maybe my biggest claim to fame is that I actually registered not only cachexia.de for my own email, but actually also cachexia.com, .org, .info, I have them all. Now, that doesn't mean you can make me an offer. I had already received offers and refused them. We are using them for the Cachexia Society, for the journal, and these things, but it's never too bad to talk about these things, and we will see. Now, you might be surprised about this slide as the first slide in a trial methodology kind of talk, but it's an important slide. And this is a really great work that Eric led there with the ASCO guideline. And yes, in the ASCO guideline and the other guidelines that are out there, there are some good statements about what you can possibly do with your patients. But when you are doing your next trial, one of the important things will be the following question. What is the standard of treatment that you're providing to all of your patients on top of which you test your intervention? And the coolest thing is if you are able to say, usual care and I don't care what it is. And this guideline, taking a slightly sarcastic view, but only slightly, with a good intent, allows you to say, well, you may offer dietary counseling, okay, may. Enteral feeding and parenteral nutrition should not be used routinely. And then actually clinicians, and this is the most important sentence, clinicians may choose not to prescribe medications for cachexia, that is. In other words, they can do what they have always done, which is close to nothing. You give your new treatment on top, and you hope it works, because it's from a practical standpoint. If you start to now consider what nutrition do I add, what exercise do I add, you know what you do? You will have 2 years of advisory boards. You waste 2 years and you cannot come closer to any good solution of the problem. The good treatments of the world work regardless of the background. This is what we need to do, and this allows you to do it. Now, how can you develop your therapies? Well, you can do and I've done all these things more or less, I should say. The mechanistic preclinical research I've done the least, but most recently with a few of the involvements in new developments, I'm even doing that. Learn from clinical trials, assessing weight changes in one trial program and see whether it's a useful conclusion for another one. And we've done that. Comparative epidemiology, we've done that. And you basically, you assess in different cachexias neurohormonal changes, make your conclusions that counteracting these neurohormones may be a good thing. And particularly, you find that in starvation, these neurohormonal changes do not exist. And then you basically have a cachexia-specific neurohormonal pathway that you may target. You get patents, you get new treatment ideas. You may also do, of course, your muscle and fat tissue symptom analysis and all sorts of other things. So what can it help if you look at symptoms? What can it help if you look at cause of death? Well, here are the causes of death in cancer. Very few studies exist. Infection, half of them. I'm not aware of a real trial program for cancer cachexia targeting infection specifically, but I bet it could work, at least for symptoms. Here you have some other symptoms that are related to GI issues. Maybe they could work. Well, now let's take a cardiovascular perspective, and that brings us one step closer to what I will say in 5 or 10 minutes about cardiac wasting cardiomyopathy. 1/4 of all the deaths is cardiovascular. I'm not showing you today data on this, but there is severe arrhythmias, and you can target sudden death in cancer cachexia. That's possible, and we are going to do this. You can target dyspnea. Dyspnea is 50% of the patients. Fatigue and weakness, that sounds all like heart failure, and this essentially triggered us to do what I will show you later on. The comparative epidemiology part is also from a trialist standpoint important. Which is the most frequent cachexia in the world? Actually, it's COPD cachexia. Second is heart failure cachexia. Now comes the big question. Is cancer cachexia one disease or actually 20? Well, it's at least 20. For the regulators, cancer cachexia at this moment is different for each individual cancer, and you will get, if you develop a therapy, an approval only for that one cancer cachexia you targeted. If you have 2 of them, you still only get 2 indications. But if you make it to 3, then suddenly you have a real chance of having a pan-cancer cachexia indication. So think about that when you do this. So here's US data. All of these different cancer cachexias are orphan disease. The same in Europe, doesn't matter which definition you need. Here's the margin for orphan disease. All of these cancer cachexias are, theoretically speaking, orphan disease. Now, is there a chance of getting an orphan disease status when you treat and prevent muscle wasting in cancer? Absolutely not. You will have basically 50% of all cancer patients. So orphan disease status for that, not possible. What's the benefit of having orphan disease status? Well, you only will do 1 trial. By the way, only a few weeks ago, a new FDA guidance came out, how to get approval for therapy with 1 trial only. Very important guidance for our field. Orphan disease is not only the only way forward, you may also have fast-track designation, high medical need status. In Europe and America, there are different words for this. So basically, you can also then have this approach of doing muscle wasting and cancer. What difference does it make? Well, suddenly you're talking to the oncology division instead of the endocrine division. You get very different answers from these people. Can you get orphan disease status? Yes. This was achieved by ARC Therapeutics. This is a long time ago, 15, 18 years, and they basically had this. What did they achieve? Now, this is a long press release. You can no longer find on the internet. The summary is on the right. 200 patients included, significant body weight and hand grip strength results in non-small cell lung cancer and colorectal cancer. But they were greedy. Against the advice of the FDA, they also included pancreatic cancer patients, and that turned the whole trial program neutral. Bad luck. They had 42% dropout. That points to a very big problem in all clinical trials, and Vicky kind of said, you want people to survive the intended therapeutic phase. That is true as a real problem, unless, of course, your primary endpoint accounts for dropouts in some ways, and I will show you in a second how you can possibly do this. So ARC Therapeutics is also relevant for the cardiac wasting original talk title, because you may or may not know this is an ACE inhibitor. ACE inhibitors can prevent wasting in all diseases. They cannot build tissue. They prevent wasting, they do not build tissue, in contrast to many other cardiovascular drugs. So this is the GTX enobosarm statement, and this is from Jeff Crawford's presentations in 2013 at ESMO. And why do I show this? Well, because sometimes you think you need to have 1 primary endpoint. Well, not true. You might have 1 primary endpoint or set of primary endpoints for EMA and 1 for FDA, and this was happening in the case. There is 1 trial in cardiovascular medicine that had 3 sets of primary endpoint, where 1 was for EMA, 1 for FDA, and 1 for the New England Journal. The academic endpoints were different than the company endpoints. And the second thing to say about all of this, sometimes regulators, sometimes your own thinking makes you to really push for muscle mass to be part of the primary endpoints. Don't do that. First of all, you never get any medical guideline approval or other benefit for having done that. It's enough if it's a secondary or tertiary or exploratory endpoint. It's totally enough for mode of action discussion. But you actually waste alpha. The most valuable thing in a trial is the p.05 kind of criterion for success. And that you have this 0.05 in a trial only one time. You can spend it on one endpoint, you can spend it on several endpoints, but you cannot spend it twice. You only have 1.05. Don't waste it on things that you will not get any credit for. So what happened there in GTX? Well, they were significant for one of the two co-primary endpoints in one trial, not in the other. By the FDA standards, by the European standards, they were successful 3 out of 4 times. In the end, they didn't go for registration. So this is an incomplete list of ongoing trials, and unfortunately, the top 3 didn't make it. My little hypothesis here is all of them increased lean mass, but they did not protect fat tissue. They did have very modest or no body weight gains in the final studies. That means they had a lean mass increase at the expense of fat tissue. And I think that a good cachexia therapy should at least keep fat tissue neutral, ideally have also a little bit of an increase for it. I think that body weights correlate with each other. A cachexia therapy on average in cancer should increase body weight. That's a good indication for having a balanced kind of result. Of course, the details are patient to patient different, but for population averages, a body weight increase is nice. Now, again, why do people assess muscle mass so frequently? Because they believe they can understand cause of mechanism. It's not possible. Basically, Karl Popper taught us that the only way forward in science is falsification. Trying to find a positive relationship. You can try to do this 20 times. You have 20 times proven, you think you have proven a positive relationship. It still doesn't logically constitute proof. You need one negative example for your hypothesis, and your whole hypothesis is gone. So what you need is falsification. You can understand why something does not work. You can never, technically speaking, understand why it works. You can think you understand that it works, but you cannot really prove that point. So you might as well not spend alpha on muscle mass. Do your body composition assessments in the trials. You will be asked to do this. Do it as a sub-study. Do it as a tertiary endpoint. Do not make this primary endpoints. It's a waste of time and money. Well, basically, if you then move forward with your treatments, try to develop multimodal approaches. If you don't want to give nutrition as a standard background, why not increasing appetite? So make the people eat more and be an anabolic, be an anti-inflammatory, be a modifier of metabolism, be whatever you want, but have a little appetite component in it. That negates the need for having underlying nutrition. Well, and if you have actually a little anti-fatigue component in your treatment, that negates the need for exercise because you make the people more walking. And so multimodal treatment approaches are cool. And I would say at this moment, I know 2 treatments that try to do this. One is the GDF-15 antibody, and this is now phase 2 with Pfizer, and here's Actimed, and this is a press release about 10 days ago. We have a positive IND for a phase 2b/3 study. That means dose finding and efficacy proving in one trial program in a seamless adaptive design. And what is basically the whole point about this? The drug espindolol, it's the S stereoisomer of the very well-known beta blocker pindolol that essentially is no longer available for purchasing. And even if you do purchase it, you have a racemic version, which is the left and the right. The right version disturbs the left version. So you really want the left version in isolation. The left version isolation is a beta-1 blocker, reduces catabolism, beta-2 agonist, so it's an anabolic. And then this is a specific for only 5 beta blocker left stereoisomers, 5 in the world, that they would also hit on 5-HT1 alpha, which is serotonin. They decrease fatigue and increase appetite. This is all one small molecule, doing all of this together. And basically in cancer cachexia, we see with a beta blocker, an ordinary beta blocker, 1 kilogram per year. With this drug, we saw 1 kilogram per month weight gain in cancer cachexia with lung and colon cancer. And that's why lung and colon cancer is now the trial programs we are moving forward with. We had 87 patients, not only this weight gain, it was 2/3 muscle, 1/3 fat tissue, and it had a hand grip strength increase, but now we need to do this in bigger extent. Now, colon cancer and lung cancer, Vicky is showing this slide. I'm trying to emphasize something else here, Vicky. We are recruiting in this grade 3, 4 cancer cachexia space with lots of mortality. Plan your trials with an upside for mortality benefit. Mortality benefits are the easiest thing to count. It's simple counting, simple statistics, and everybody contributes to the endpoint. So mortality, and maybe in the future also hospitalization could be part of it. The endpoints discussion, you feared functional performance, there's many different ways of doing this. But here's the extra point I'm trying to make on top what Barry so elegantly showed. Try to combine endpoints of different kinds of mortality, functional capacity, quality of life in one endpoint. Can this be done in a reasonable way? Absolutely. And one way of doing this is called the win ratio. Now, the win ratio is enabling you to recruit, for instance, as an example, 200 patients, 100 in one group, 100 in the other group. And now you don't make a statistical test of the averages in the one group and the averages in the one. You do not do that. You compare each patient of the one group with each patient individually of the other group. That makes 100 times 100, 10,000 comparisons. And then you develop a hierarchy of testing. Your first test is death. Whoever lived longer is the winner. Now, both might have lived the whole treatment period, so therefore they are both winners, it's a draw. You move to level 2, which is number of, in this case, heart failure events. This is Nature Medicine published trial that is an officially guideline recognized, regulatory recognized trial in cardiovascular medicine of empagliflozin in acute heart failure. So you take heart failure events, and then you take the change in, this is a quality of life questionnaire. You can most recently look at the STEP HFpEF trial. You might say, what is that? Well, New England Journal 2 weeks ago. It's basically semaglutide for heart failure with preserved ejection fraction. They had an 8-step win ratio test where they had death, hospitalization, weight change, quality of life, and CRP even as part of a win ratio test. Overwhelming win, highly significant. So what you're doing, basically, you compare your patients 100 versus 100 for each of these things, and then you basically say, well, how many wins and losses do I get for each of these components? And you do a summary, and let's say in this case, 54% win for the intervention, 40% win for the placebo, a few draws, and you get a 36% clinical benefit. Here is a win ratio, 1.36. You have a confidence interval, and whenever you have a confidence interval, you have a p-value. So now you've combined all these endpoints together, and you make your trial very much more powerful, and now you no longer need to survive your intended treatment period. It's not a problem. If you have a trend for mortality benefit, a trend for muscle strength benefit, a trend for quality of life, well, together you get this. And this is a new methodology, I believe, that is perfect for cancer cachexia. And of course, within those endpoints, you need to select clinically meaningful thresholds for the quality of life and the strength improvement. Typically 10 to 15% for some interventions, a little less, but you can establish with anchoring approaches, don't forget these things, it's very statistical, but anchoring variables, you need to ask the patient whether they feel moderately or very much better, and then one amount of feeling better is one increment, and you need to relate your functional test to this amount of incremental feeling better that the patient tells you about. So statistical points that make your work much more efficient. Let's assume you have funding for 500 patients for a functional kind of output cancer cachexia trial. And you do one assessment at the beginning and one assessment at 3 months. But now somebody says to you, well, we have the Ukraine war and we have an energy crisis. Could you actually live with half the money? And then you say, well, there's a very simple solution. Double the assessment at baseline, double the assessment at the end of the trial, and voila, you only need half the patients. Why is this? Repeat assessments halve the the variance of your assessment, and with that your power increases. And now you say, well, now I am actually getting a taste of this being efficient with my testing. If you now introduced a fifth test in between, baseline, 3 months, but you also do a 6 months test. And instead of doing repeat assessments only for beginning to the end, you actually do the middle test as well. You halve the coefficient of variance again. And now suddenly, with half the money, you make a profit because you now no longer need 250 patients, you now need only 125. And suddenly, your whole exercise becomes really cost effective. This is the power of statistics in your own hand. Just a few tests more per patient allows you to recruit many less patients overall. And this is the most difficult thing of all our trials, getting enough patients. Okay, make sure that your test has no zero values. Zero values are the worst in statistics. Try to avoid that by all cost. Adaptive designs, well, if you're not sure how big your trial should be, have a certain trial size planned, but have an in-between assessment. It's called conditional power assessment. Enlarge your trial only if it has a promising zone result. So only throw your good money after a trial if you know it will be well spent. And that's called promising zone approach in part of the adaptive design. Well, avoid responder analysis because they only test in one direction. Push for continuous variable assessment because that gives you more statistical power. Bob Temple from the FDA once said publicly, anybody doing any trial with only one primary endpoint is actually, he actually said, silly. That's inefficient and should be prohibited for corporate governance because it's really abusing your funds. Have more than one primary endpoint and use clever statistics, at least in a field like ours, where you don't have the resources and the capacity to do thousands and thousands of patients. Cardiovascular may be a little different, but in our field, have more than one primary endpoint, use clever statistical approaches with the Holm or Hochberg procedures. It's really possible to have this. Of course, hierarchical testing and alpha redistribution. And then again, as I said before, combined endpoints. So really, when you do your trials, you need to think about where you're doing it. Now we come to the cardiac wasting part, because we are now doing it somewhere where nobody else at the moment, as far as I know, really does it, in refractory cachexia, at the very end stage of life. This is where you have cardiac wasting. This is where we hopefully make a difference with a slightly different approach to the cachectic patients with cancer. Why do they get heart failure? This is the normal heart. This is the heart of the cachectic patient. The wall gets thinner. The diameter doesn't change, but the wall getting thinner results in wall stress being increased. That's exactly the same as you've learned in medical school with the Laplace law when you have dilated cardiomyopathy. The radius goes bigger, the wall only stays the same or gets slightly increased, but you have a wall stress increase. That's the core, physically speaking, the core of cardiac failure, happening in dilated cardiomyopathy, happening in cardiac wasting cardiomyopathy. It does actually happen in reality. We just published this 3 months ago in JACC. And here is the cancer patients without cachexia. Here's the cachectic cancer patients. Compared to the healthy people, they have 20 to 25% less left ventricular mass, not 10 or 14%, 20 to 25%. Chemotherapy has no impact, so this is just to show this is not a toxicity issue at all. And this is over time. And you saw the data that Vicky has shown to you about skeletal muscle change. Each dot represents a change, and here you see the time span in months, 2 months, 3 months, 4 months, and all these people here had more than 20% muscle wasting of the heart in 2 to 4 months. On average, 9% loss in 4 months in 90 patients, all stage 3, 4 cancer. These patients basically had a poor prognosis that directly related to the cardiac wasting. Importantly, best when you do the adjustment for height. And some of you know, of course, or many of you, that body surface area adjustment is really biased because it has body weight in it. So height adjustment is much better. This prognostic value was independent of all these other cardiovascular factors. So cardiac wasting independently of anemia, of natriuretic peptides, troponins, kidney function, CRP, independently prognostic. And is this really relevant? Yes. Now here is the standard thing to do. It's an ejection fraction assessment. So this is left ventricular ejection fraction, and you all know that 60 and more is normal. So healthy people, 68%, all cancer patients together, 64%. Normally, that's the end of the story. Here you have the patients with cachexia. Here you have the patient without cachexia, 63 and 65%. Normally, that's the very end of the story. The only problem is this. Oops. The only problem is that in the end, what you have basically is a change in stroke volume. Here you see the stroke volumes. 63 milliliters for healthy people. For cancer, 53. That's already a 15-20% reduction. But look here at the patients with cachexia. They have very low stroke volume, which is as low as that of heart failure patients, despite the ejection fraction being very similar, very different. Ejection fraction means nothing in advanced cancer. Stop your cardiologist to ever tell you ejection fractions, get yourself stroke volumes from these patients. And when you have cardiac wasting, you have poor performance, not only gait speed, you have also stair climbing power reduced, 6-minute walk test is reduced. And doing this at the very end of life, this is 120 patients with a median survival of 51 days. Half these patients were not even able to walk 4 meters. That's from here to Barry, because let's say where Barry is the shower or the washing room or whatever, they couldn't walk there. Half the patients at the day of assessment were not able to wash themselves. And the whole point is that we are trying to develop at the end of life meaningful endpoints for these patients that even in the scenario of being dead in 1 to 2 months makes a difference to their lives. And the dignity at the end of life, the ability to wash, we believe, is part of this. We have now a clinical trial running with BfArM approval, not easy, I can tell you, because it's 4 treatments at once. Sacubitril valsartan is basically a cardiovascular drug to improve RASI activity. Empagliflozin, SGLT2 inhibitor, this is heart rate regulation, ivabradine, and this is intravenous iron. You may ask, why not a beta blocker? Because they make fatigue in the first weeks. Why not an aldosterone antagonist? That's also heart failure therapy, because you get hyperkalemia. So we excluded drugs with some degree of a problem, put them all together, and we assess days alive and being able to wash yourselves. Days alive and being able to wash yourself. So death is the component, and the washing ability is the functional endpoint, all in one endpoint, and we will see. So let me come to the conclusion. Treatment development approaches, there are many of them. I highlighted a few statistical tricks with the repeat assessments, with the adaptive design, more than one primary endpoint, and have combined endpoints. And my very last slide is basically a few other little issues. Have you ever thought about having a placebo run-in? Now, if you have one dropout in the first week of your trial, one dropout, on the average trial, you need to recruit 10 to 15 patients more to recover that one single dropout. Now, let's assume you have 10 dropouts in the first week. Now you have to recruit 100 to 150 patients more. To avoid this, have a 1-week placebo run-in. Any dropout in that period doesn't count because the randomization is after the first week of placebo. That actually alone can save you a ton of effort and resources. Don't forget, phase 2 is not about proving really efficacy. It's about getting the funds to do the next study. That's all what phase 2 is about. And basically, and a little regulatory acceptance that what you do is a reasonable thing, of course. Do not burn in phase 2 your most preferred endpoints. Choose something where you win for sure, but your most beloved endpoint, keep it as an other endpoint or something. You need to get some idea how the response is, but don't burn it statistically by making your preferred endpoint a primary endpoint. Do not do that. Absolutely not. Oops. Anyway, doesn't matter. There's other points that I would like to say. Really, do the trials prospectively and basically have fun. Cheers.